Excellent. So yeah, good morning, everybody. A bit some more people. I'm Chris Carrigan, and this is the third of the sessions we've done with Flatiron Health Patient Panel. They can introduce themselves in a second. You will see some familiar faces. June is a packed month, as you'll have seen, so it's really great to see loads of people from sessions 1 and 2 have returned, and welcome to some of those who are here for the first time. We've got lots of patient data events run across June, which will all lead up to National Patient Data Day, of which Flatiron is one of our key sponsors for that data. So thank you to them again. And this session is one of several umbrella events that are running in the run up to June, the 24th of June. If you're not registered for the 24th, hop on the website, look in the newsletter, and register yourselves. Just a quick reminder about normal etiquette stuff. If you could keep your microphones on mute while you're not talking, it's up to you what you do with the cameras. It's always good to see some people, but I know bandwidth is a problem with some. We can use the chats throughout. Everybody can see everything in the chats, and you can use the hands as we go through as well. You can put your little hand up and you can raise questions that way, or you can just wave at me or Janet, the co-host. We'll try and keep an eye on things. The captions and the transcripts are available if you want them. You can just switch those on and manage them yourself, including things like caption size for easy reading. If you're not sure of a question, please ask it anyway. Just to note also, we don't, with all these sessions, we don't all agree on the same things. We don't need to agree on the same things. It's fine to disagree or to ask somebody a question, but don't be disagreeable in the way you do it. We always run under a principle of positive engagement in all our sessions. You'll have seen that we're recording the session, and we're going to try and record the breakouts later as well. So you'll each be dropped into a breakout. When you go into the breakout room, you'll be moved automatically. So it's nothing for you to do. And when the breakout finishes, you'll come back in automatically, or there'll be a little button if you want to leave early. The format's slightly longer, like 90 minutes, just to try and tie everything together from this series of 3 sessions with the Flatiron Patient Panel. So I think that's enough from me. That's probably all I wanted to say. If you've got any problems, you can always message me or email me or just wave at me. So let's get the session rolling to start with. Janet, am I handing over to you or?
I'm just going to share my screen and then Jeff will introduce everybody.
Over to me, Janet.
Yes, please. Thank you.
Thank you very much. Good morning, everyone. My name's Jeff Rollerson. I'm a member of the Flatiron PVP. And this is the third and final webinar in our series where we bring together the learnings, bringing measurement into practice and focusing on how PPIE impacts organizational culture change. We're going to look first at how PPIE initiatives have the ability to transform organizational culture. And then we'll hear some real-life examples from members of the Flatiron PVP to demonstrate what has and hasn't worked looking at cultural indicators. We're also going to look at how opportunities for PPIE are expanding with new roles in governance. And then next you'll hear about the Flatiron PVP is working to change attitudes and culture and discuss honest insights into what's working, what's challenging, and what we're learning. The interactive breakout sessions will give everyone an opportunity to discuss your own measurement challenges and share experiences, and hopefully you'll have been able to give some thought to the pre-work. We'll finish by summarizing all 3 of the sessions, and there'll be an opportunity for question and discussion. So, without further ado, here's Helen, who will start proceedings by setting the scene.
Thank you, Jeff. Hello, everybody. It's lovely to be back in this space again. So, yeah, just one of the PVP, one of the panel members also use a lot of data to support the communities who are living with brain cancer. So I'm just going to set the scene and talk about why culture matters as much as a process in PPIE. And one of the things I want you to do as I go through the next sort of 10 minutes or so is to think about you as being, if you like, the mortar between the patient community and maybe the organizations that you're working where you're trying to shift the culture. So think about maybe 1 or 2 takeouts that you could take back to the organizations where you've seen that there is opportunity to develop PPIE, take it further when you're working with the people there. I think, you know, the key message is that PPIE isn't just a compliance checkbox, and we all know when it's done well, it changes the way people inside research organizations think, work and lead. And that's a culture shift. And we all know in any aspect of trying to do a culture shift that they're hard won. I'm aware too that some of you here today are seasoned PPIE practitioners. Others, you know, you might be new to thinking about organizational dynamics, but this presentation is for everybody. Could I go to the next slide, please, for the setting the scene? So many organizations can point to a PPIE lead or a patient advisory group or a PPIE statement in their grant applications, but structural compliance is not the same as cultural embedding. And in fact, I came across this yesterday when I've suddenly been given a review of the detailed patient involvement plan for some research where I am the PPI lead, and the clinicians haven't been in touch with me at all. So I'm going to fill it in honestly. So, you know, research consistently shows that PPIE undertaken as a box tick exercise produces minimal impact. And we as patients notice the difference, and so do staff. So I think the opportunity framing here on the right-hand side of this slide is deliberate. This isn't about blame, but it's about potential. It's about looking for opportunity. And organizations that have made the shift report better study retention, more relevant research questions, and critically, more motivated and ethically confident staff. Next slide, please. So the transition to understand how to shift culture, we need to understand what cultures we're working with. And I think typically we tend to go in and assume that we're working with one organization, but we're not. There's a huge amount of organizational pluralism. There's no single culture to shift. And that's what makes it really hard. Because one of the most common mistakes in PPIE culture change work is treating the organization as a monolith. But in reality, most research organizations contain several coexisting cultures, each of which will have its own value system, its own language, and its own motivators. So you've got the scientific culture, and the language of rigor is powerful here. We need to frame PPIE as a methodological asset. So patient co-design reduces recruitment failures, improves outcome measurement validity, and catches protocol issues early. In the clinical culture, the patient-facing culture, these colleagues often feel that PPIE world is telling them what they already know. And we know unless you've got that lived experience, that's not the case at all. So the shift needed is from empathy as a personal trait to empathy as a systemic design input. We need to help researchers and clinicians to see their clinical insight as a bridge and not a barrier. And then operational culture. The return on investment language works here. Poor PPIE contributes to failed trials, poor recruitment, and regulatory challenges. And you can see that reflected when you're trying to roll out a trial and they have to keep going back to ethics to make changes because they didn't get it right in the first instance. So good PPI here can be seen as an efficiency tool. And then senior leadership culture. Public trust in research has never mattered more. And PPIE is a reputational asset and a funder requirement, but it's also a genuine differentiator in competitive funding landscape. Next slide, please. So how do we move from compliance to conviction? Because this is all about shifting mindsets. And we all know that mindsets precede behavior. Before you can change what people do, you need to understand what they believe, what are their values, and then create conditions for those beliefs to evolve. You know, so the patient's lead job, everybody's responsibility. PPIE cannot be siloed. And when the PPI lead leaves or is off sick, the PPIE should not collapse. And so distributed ownership is the key here. Because the funder requires it, because we need to make research better. This is the deepest mindset shift. It requires evidence. So that's where we have a role. We can share impact stories, case studies, trial outcomes where PPIE made a measurable difference. So the you said, we did. And then patients validate our work. Patients co-create. Validation is downstream, co-creation is upstream. And so the shift is temporal as well as philosophical. So having patient involvement in designing the research question while it's still just an idea in the researcher's head is absolutely key. And then we consult at the end. We involve from day one, protocol design, ethics application, framing, outcome measures, selection. All of these benefit from patient involvement before the research machine is in motion. PPIE adds time and costs to shift to PPIE as an investment. Recruitment failures, protocol amendments, and participant dropout are far more expensive than front-loaded PPIE. So we need to frame the return on investment explicitly. So which of these might stay with you after these sessions for you to reflect on and take back to any organizations you're working with, because that can spark useful discussion. So next slide, please, which is looking at the 3 levers that actually move people. So lever 1, the direct human contact. The evidence base we know here is strong. When researchers meet patients as equals, not as subjects or beneficiaries, their orientation shifts. And that's why embedding patients in team meetings, not just advisory groups, is so powerful. One good conversation can do far more than a day of PPIE training. And then the second lever, narrative alongside data. We all know that stories are really important. Researchers are trained to be skeptical of anecdote. They regard real-world data as shifty. But neuroscience tells us stories activate parts of the brain because they go into the limbic bit of the brain that statistics don't. The skill is curating the right story for the right audience and making sure the story is offered with consent and agency by the people who are sharing it. And then the third lever, psychological safety. This is often the missing piece in PPIE culture work. Researchers who fear being seen as ignorant or insensitive will perform PPIE rather than do it. So creating a culture where I hadn't thought of that, tell me more, is celebrated rather than embarrassing, is foundational. Next slide, please, where we look at how do you move from aspiration to infrastructure, what patient-centric practices actually look like. This is the practical core of cultural transformation. Good intentions produce rhetoric. Good structures produce change. So structural practices, the single most powerful structural signal is budget. If PPIE has a protected budget line, it signals institution commitment. If it has to be justified or fought for each project, it signals tokenism. Patient partners on hiring panels change who gets recruited and sends a powerful message to all candidates about organizational values. Then you've got the relational practices. Payment is non-negotiable as a principle. Unpaid PPIE excludes those people most affected by disease, those who can least afford to give time for free. So reciprocal feedback, that's what changed because of what you told us. So you said, we did, is what keeps patient partners engaged over time and signals genuine respect. And then cultural practices. Induction is the moment of maximum openness for new staff. Embedding PPIE values there, not as an optimal module. I think somebody's waiting to come in. Chris, thank you. Senior leaders who model PPIE engagement, who attend patient advisory meetings, who acknowledge patient input in presentations, create permission for the whole organization to take it seriously. Next slide, please, where we're looking at embedding patient voices through the research cycle, which is the structural argument. And most of you, I think, will be familiar with this. The priority setting. So the James Lind Alliance model, for example, shows that when patients, caregivers and clinicians jointly identified unanswered questions, unanswered priorities, the resulting priorities look very different from researcher-led agendas. This is where patient involvement has the highest leverage and the lowest adoption. And certainly my experience when we ran the James Lind Alliance PSP for Neuro-Oncology completely transformed the research landscape because it was embraced by the NIHR. We managed to get funding from the NIHR to do 8 of the synthesis evidence reviews through Cochrane. And now no research in neuro-oncology will be done unless it's tied back to the priorities that were identified by the community. Study design, outcome measures chosen without patient input frequently don't capture what matters most to those of us who are living with the condition. Consent language drafted without patient review is often incomprehensible to potential participants, and both are solvable with early involvement of the patient voice. Funding applications increasingly scrutinise PPIE sections. A well-evidenced, co-authored lay summary signals a research team that understands the value of patient partnership. That's a competitive advantage over maybe another funding application that hasn't gone into that space. Recruitment is the biggest operational challenge in delivering clinical research. Patients who've been involved in designing a study become its most credible advocates. Site cultures that feel patient-friendly get better retention. And then analysis and dissemination. Patients bring interpretive insights that researchers miss. They also know where the findings need to go, which communities, which forums, which formats, so that they'll have a real-world impact. Next slide, please. These are the diagnostic questions you can use when you're going into organisations to work with collaborators there. So marker 1, a patient shaping the research agenda. The gold standard here is co-applicant status on grant applications. That's relatively rare, but I think is becoming increasingly common in UK clinical research. Publication co-authorship, not just acknowledgement, is another signal. Then PPIE is being visible in team culture. Can the PI of the application name the patient partners? Do they reference patient partner perspectives in team meetings without prompting? Do staff across the disciplines, not just the PPIE lead, talk about patient engagement and involvement as part of their work? Those are indicators of a culture shift, not just process indicators. And then impact is documented and shared. This is about closing the loop. You told us X, and as the result, we changed Y. Sharing this explicitly with patient partners maintains trust and demonstrates respect. Sharing it publicly in annual reports and publications demonstrates institutional commitment. And then PPIE surviving personnel change. This is the resilience test. If the PPIE activity is entirely dependent on one person's commitment and memory, it's vulnerable. So embedding it in governance structures, job descriptions, induction programs, and institutional memory, not just in one champion's diary. Next slide, please. Looking at the barriers and how we navigate them. You'll have all heard these. That we don't have time is usually a project management problem. PPIE woven into existing processes, so ethics meetings, team briefings, protocol reviews, takes far less time, additional time, than PPIE added on top of a completed process. So the argument is front loading, not adding. Patients aren't experts, and this betrays a narrow definition of what we mean by expertise. Clinical and scientific expertise, of course, is absolutely necessary and insufficient on its own. The researcher who's never lived with a cancer diagnosis cannot replicate the insight of someone who's navigated the diagnosis, the treatment, and the healthcare system. These are complementary, they're not competing. The we already do this argument, one of the most frustrating to navigate because it closes down the conversation. But we can open it again with specific non-threatening questions. That's great. Can you share an example of a decision that changed because of patient input? The inability to answer the question reveals the difference between activity and impact. It's too resource intensive, so meet this with data. What did your last protocol amendment cost? What was the recruitment failure rate on your last trial? What would a PPIE-informed design change have cost by comparison? And if they don't have the data, they need to start collecting it because that's going to become the most powerful advocacy tool. Next slide, please, which I think is my last one. So this is for you to take away and take back into organizations where you can see an opportunity. So take these conversations, ask whoever it is you're collaborating with, for example, to identify one place in their current works, to ask them to find the gap. It's not PPIE in general, but ask them to talk about a specific study, a specific decision point, a specific meeting. So small, tangible steps that they can see as being navigable. Large systemic ones are overwhelming. The other thing you can ask them to do is to name the barrier and find an ally. Culture change is not a solo sport. The most effective PPIE advocates work in pairs or in small coalitions. So Ask them to identify one person in their organisation who shares the conviction around PPIE and agree to support each other's PPIE work. And then action 3, document one impact. This is a very tangible action. Impact documentation is the engine of culture change. And when researchers see evidence that patient input changed something, a primary outcome measure, a patient information sheet, a recruitment strategy, that's when they will start to believe in it. So start with one, be specific, and get them to share it with you. So the question is not whether to do PPIE, but how to do it in a way that is genuinely felt by patients, by colleagues, and by the people that are leading the research. Thank you. I think now I hand over to Brian. No, Kaz. Yes, thank you.
Hi guys, thank you for that, Helen. My name's Kaz. You've already seen me at previous webinars. I'm part of the Patient Voices Panel at Flatiron, and I provide a lived experience of working with NHS organisations, charities, and even pharmaceuticals. In terms of what I'm going to describe today is basically following on nicely actually from what Helen has mentioned. I'm going to give you an example of my own experience of PPIE for when I was part of a team that was pitching for funding for an MS app, which is multiple sclerosis. Next slide, please. So how did we go from included to being essential? So first of all, the team involved had people from the NHS, university partners, and you can imagine people who are involved in the research side of things. We also had senior project leads, so it was quite interesting to see the type of people that were there, the seniority of the people, and I suppose what they were bringing to the team. We also had healthcare professionals. I, for one, noticed that my own neurologist consultant was there, so it was actually nice to be part of the team. So I suppose it was good to see that the seniority of people that was there. We had tech partners as well. The tech partners were there to help us, not so much with the health conditions themselves, but they had the experience of building technical applications for healthcare. And in terms of myself, I was providing the lived experience through PPIE. And you can see there the whole of five parts of that team were all, I suppose, seen as an equal part that was required. So you can see that just in the bottom bit, the patient voice was not an add-on. It was shaped in the planning, the story, and the whole credibility of the project. So it was there from day one. It was something that needed to be addressed, and that's how we approached it. Next slide, please. So the moment culture shift started to change, and I started to shift, and I actually saw this with my own eyes and felt it in the room. So what did change when lived experience became visible in a room full of organisations asking for funding? So just to draw you a picture, here we were walking into a room, our team, with 15 or 20 other organisations asking for funding, and we were talking, and we were basically walking into a room, having our table, little banner over there, and hoping the funders would come to us and ask us more about what we were doing. So we had, it says there in the boxes, we had project evidence and the organisational case, which all 15 or 20 organisations did. And then the lived experience and local credibility. It was actually quite a strange moment. As soon as we walked into the room, one of the CVS team who were actually asking for funding came up to me, shook my hands, said, Kaz, how are you doing? Great to know. Oh, tell me more about this. So it was like all of a sudden the focus shifted from the people who had probably more initials after the name than the king to someone like me who was just providing that lived experience. And they were like kind of ushering me ahead then, saying, oh, Kaz, yeah, tell them about this. So it was really good to see that lived experience was almost like not quite a deciding factor, but a big factor. Why did it matter? Because obviously I understood the condition. I brought a lived experience, which I suppose we all do when it comes to PPIE. I was known locally as an advocate, so people knew that I was fully vested into the subject. We explained the real world value because if you think about it, anyone that's applying for funding or research funds has got a good idea. I mean, everyone does it for a purpose. But what we added was we explained the real world value. So when they asked me, Kaz, what are you doing? I didn't tell them about the technical abilities of the app. I didn't tell them about how much time we'd spent on the research. I said it's how it's going to help people like me. And I think that was one of the things that made a difference. And finally, it made the project feel credible. So it wasn't just another funding application. This was going to make a real world difference. Next slide, please. So measuring the cultural shift and what we noticed. So the impact of PPIE is also how it changes the organization. And once again, touches on what Helen mentioned. First of all, staff attitudes. So from where it should be, we should involve patients. It went, we need to find the right patient voice earlier. So I think inadvertently, I created a bit of a competition for PPIE. So rather than just saying we just need to find someone, it was right. Hang on, we need to find the right person because this could make the big difference. The involvement frequency, PPIE becomes a regular part of the process, not an optional extra or a tick box, because in the past or even now in some cases, it's like a case of, right, have we done the PPIE? Right, okay, great, we've done that. So it almost feels like a tick box exercise, but this kind of changed it completely. And the people in the team could say, actually, this is really making a difference. In terms of the decision making, lived experience informs priorities, language, and how the project is explained and can be the deciding factor. And when we saw this happen in real time in front of our eyes, it wasn't just a learning experience for me. The rest of the team, they were like, wow, this is really making a difference. It wasn't, I mean, they didn't see it as a tick box for 1 minute. I was involved from right from the start, but it was nice to see the vindication of that. And then the responsiveness. Teams can see how public trust and credibility can influence the outcomes. So PPIE does not only improve projects, it can change how organizations think, behave, and build trust. And you can see how it's about a case of winning hearts and minds. And when people see an action, then you don't need any more evidence. You can see the information in front of your eyes. Next slide, please. And now I'll hand it over to my colleague, Linda, tell me more about her experiences.
Thank you. I'm Linda Galbraith. I've been involved in PPIE for 4 years now. I first joined a project called RadNet, which was to encourage radiation research, which has been pretty poor in the UK over the last 20 years. And this has helped boost that. And it was my very first experience. And when I turned up, they asked what I would like to do. And since my working life had been strategy and funding, that was what I said, and said, that's great. And when I went to my second PPI, another organisation, and said that, they were kind of, don't be stupid, you're a patient, was really the message that I was given. I thought, oh, right. And RadNet was great for me because I was able to use previous skills I developed into helping start a new and exciting project, and I'm still very much part of it today. And the one thing that I enjoy most in that is actually the fact that you build up such close relationships with the researchers, starting with early career researchers, and the one that I'm very privileged to be part of was one that started as preclinical and is now moving to be first in humans, and I'm still involved in, and that is a great privilege. Next slide, please. And you're glad to know I've just got the one slide. And just looking at the expanding roles for PPE that I've seen in the time that I've been involved. The first one is in governance, and that has been a lot of my working life. So in various projects that I am on the strategic panels, the funding panels, and looking at governance. I suppose the largest one I'm involved in is ACE, which is an early diagnosis of cancer. A project which is a global project in the US, bits of Europe, and the UK. And it started out, we had an incredibly talented team of patients who have been working in PPI much longer than myself and had a variety of backgrounds, and we weren't using that at all. So I was the chair of the patient group, so I attended the executive board but didn't have a vote. So I suggested that we needed to have a vote, we needed to expand. We had all this potential there to work with, and so they said, okay, go and write us a report, and I did, and they agreed to the changes that I suggested, which has been terrific. So I now have one of the 6 people who have a vote on what we're going to spend the money on, what the research is going to be, and to help make those decisions. And we're looking at it throughout. We are also appointed a patient as a member of the, I've mentioned it later, in the scientific board, and we're looking at ways we can involve patients from the research question right through to the dissemination at the end. It's all very much involves the culture, though, and the downsides too, because this project, they then appointed someone who is head of PPI but is obviously not a patient, and there has been no involvement in looking at job descriptions, the recruitment process, or anything, and a lot of the progress we've made is falling away at the moment. In fact, this morning I came back from holiday to a letter that had been sent to all the PPI people in the organisation saying, oh, well, we're going to get back to the panel soon because we haven't had meetings for 6 months, but, you know, do you still want to be part of it? That is very depressing and something I need to deal with after this. So it's not like we can sort it and it's sorted. We need to always keep the eye on the ball and see what's happening. But governance is very important. One of the things I found being part of the international project is there was a reluctance from my US colleagues to be involved in governance, but that is because of the healthcare differences and the litigious healthcare that is available in the US makes it a bit nerve-wracking for people to put themselves forward to be part of that. So it's been interesting to look at the geographical cultural differences. Again, in Germany, it's totally different, where the German government actually put it into law that PPI needs to be carried out at all the German cancer centres, and that has to be abided by for all the research. So it ranges from that to the US insurance-based healthcare system. So it can be quite a challenge trying to come up with policies that are appropriate for all the different places that we work in. But it is well worth doing, because for patients to have that influence, you need to be involved at that level as well. We also have looked at dissemination, and I'm part of quite an exciting project just now where we're looking at a way we can make it meaningful for people who actually take part in trials. And what we're doing there is we are interviewing the patients involved in a study, are interviewing the researchers, asking the questions that they want the answers to, rather than at the end of a project not actually finding out what the results of the study were, or being given information that is so hard to interpret what it means. So what we're doing is making a video of these interviews and making that available to the people that have taken part in the trial. And it's also helpful in other ways in terms of addressing some of the inequality issues. We're able then to have subtitles in different languages, and it's not a literacy-based way of finding out by having to have particular reading skills. So hopefully it makes it more accessible to more people. As I mentioned earlier, we are now in a looking at appointing PPI representatives on scientific advisory boards. This has happened at the Global Project, and I've recently done it in the first project I started, RadNet. We have a patient joining us from DKFZ in Heidelberg, who will be joining for her first SAB meeting next month, and that's really exciting too. And we'll see what comes of that. She was quite nervous. She wasn't sure her English was good enough, but like most research projects, people come from a variety of nations, and we actually met up. It was me and other people from the project, and I was actually the only non-German speaker in the room, which was a good experience for me to have. So it's helps all of us. And for a patient who is maybe sure of something, you're looking for help and support from others who can give you advice in what you're doing. So I hope that this will expand to other projects in the future. There's also new approaches in measuring impact as well. Helen mentioned earlier the financial impact that can have by PPI involvement being appropriate, and in some ways saving mistakes happen. And I'm involved in a project I think UCL are doing, where we're looking across the board at how we measure impact, looking at social impact, but also looking at financial impact and what happens in studies and measuring that. So I think there are lots of opportunities for patient involvement to extend from that research question right through to the dissemination and the presentation, as well as we're just at the applying funding stage. It's a global project, again, a head and neck one. It's inequalities, and it's with the WHO and South America as well, and looking at the policy changes that can help with inequalities in different countries. And part of the end of the project there very much involves the patient groups that I'm running in the UK and my colleague in Brazil as well. And we are very much involved in the final part of that and showing the impact it can have, hopefully, in people in the future. So I think the horizons are potentially huge. And the one thing I find in speaking to research, and I do a lot of talks at the universities in Scotland, is how keen people are once they look at it. And a recent one I did to master's classes, and they were saying, oh, it's just common sense, why wouldn't you do it? And I came across this wonderful slide in someone else's presentation, and did ask their permission to use it, but they'd taken it from someone else as well. And it was a picture of an architect, and he was saying, well, the architect would want to meet the people whose house he's designing, and isn't it the same that you would want to meet patients to see you're making the right decisions for that? And that's one of my favourite slides now. But as I say, it certainly wasn't created by me at all, but it's a very useful one, and it's one that goes down well with the students when they see that as well. They can immediately identify the reasons why it is just common sense and we should treat it like that. Thank you. And I'm passing on now to Brian.
Thank you, Linda. Hi, everyone. I'm Brian. I'm the head of abstraction at Flatiron Health, and one important aspect of my role is also to help support our Patient Voices panel. If on the next slide, please, Janet. So in September 2021, we established our own Patient Voices panel after a collaboration with DataCan's own patient panel. The PVP is a permanent independent group of patients, carers, and lay members of the public, and they've helped shape how we in Flatiron operate in the UK. So since those initial meetings where the panel co-created materials for how we engage with our NHS partner sites, they've been present at vital meetings to help discuss concerns to other local patient groups within the NHS kind of landscape. They have, as Flatiron has continued to establish itself in the UK and mature as a business, I've also been thrilled to see how their work as the panel has also matured and evolved. So the evidence on this slide is, the discussions that need to happen before we sign a partnership and after we sign a partnership with each trust. They have also co-authored a poster on the importance of the patient's perspective in driving discovery and innovation in real-world cancer data, which was presented in 2024 at the CRUK Data Conference. Last year, they drove and developed, without much help from the Flatiron team, a presentation at the Patient Data Day up in Leeds last year, and are continuing to engage with advancing technology such as with AI and our ML strategy within Flatiron itself. So these are like true impacts as I can see. Like I joined Flatiron around 4 years ago now, and it's been great to see how it started off as a kind of consultative initial conversation. Now it's grown to something that we require in a lot of aspects of our business. On the next slide, I'll kind of illustrate some aspects of the process of how we kind of gain access to data with each of our hospital trusts. So at Flatiron, we implement an opt-out process with every NHS partner, and this is in addition to the national data opt-out. So the goal here is to ensure that every patient can make a genuinely informed choice about whether their data is used in our research database. In practice, this means we personally notify each patient whose data could be in scope, telling them how and why their data is being used, and giving them a clear route to opt out at any time by email or phone. This process was co-designed with the PVP, with patients, the HRA, as well as our trust partners. We also ensure that there is local community support before any data is processed through in-person outreach, as well as webinars outlining the partnership. We reach patients through sending out specific letters to those that will be in scope, as well as leaflets and posters in clinic, as well as on each partner site, trust site, there will be a dedicated page outlining the partnership. To date, we've sent over 80,000 individualized letters to patients across our partner trusts. So on the next slide, we have our three main partner trusts, which are Leeds LTHT, Newcastle NUTH, and Leicester UHL. So what did these numbers tell us? So there's over 86,000 letters have been sent with just over 2,500 patients opting out, which is an overall rate of 2.96%. And if we look further into like per site, Leeds is actually our most established partner site and has the highest volume and highest opt-out rate at 4.13%. And we think this is likely reflecting our greater patient awareness and over a longer period. Okay, so if we're continuously having a presence in the trust, people will engage more with the materials that are available. And also people may change their minds. Okay, like I said, people can at any point opt out. So they could decide after 2 years, actually, I've had enough of that. I don't want to participate anymore. And whilst Newcastle and Leicester are kind of our newer sites, we would expect them to kind of hover around 1 or 2%. To put this in context, a comparable commercial model at UCLH estimates an opt-out rate of around 8%, and that's including the national opt-outs. So our 2.96% average is a strong result, with over 97% of patients who received a letter are not opting out, which suggests broad acceptance of our data sharing model. On the next slide, however, I want to be honest about the limitations about what these numbers can and can't tell us, right? So a low opt-out rate is encouraging, obviously, for us as a business, but it doesn't automatically confirms that patients are truly informed. There's an important distinction between someone actively accepting data use and someone who simply didn't respond to a letter. It's also possible that low rates in some areas reflect communication gaps in reach and rather than widespread support. And each trust is different, okay, in patient population, communication infrastructure, and local context. So we can't draw a one-size-fits-all conclusion. we see this as like when it comes to to kind of contextualize it within PPIE, like without all the work that's happened to date from the initial conversations as a business to developing simple materials for the public and patients to engage with, I really do think that like without this aspect of our jobs, and specifically my job in Flatiron and the work that the Patient Voices Panel has done and is continuing to do, it's certainly very powerful to see over the last 4 years what the impact that the panel has had. But we're continually working to improve how we can communicate, how we measure impact, and how we ensure patients are generally empowered to choose. I'll pause here and I'll hand over now to the breakout discussions.
So we've got there's 4 breakout rooms we've got set up. Each of them is led by one of the Flatiron patient teams. So we've got Jeff leading one, then Helen, then Kaz, and finally Linda. These will run for 20 minutes. It's a set time of 20 minutes, after which you'll get a notice on your screen, which gives you a minute's notice. You can either come back straight back in, or it'll come back in automatically after that minute is up. If there are any problems, people should be able to raise things in the chat. I will also put some of the questions in the chat as well, so you've got access to them. But both Janet and I are co-hosts, so should be able to get us with a message as well. Are you okay, Janet, the team, that we open up the breakout rooms now? Some seeing nods. It's okay.
Oh no, Jeff, did you want to just say a few words of introduction to it before people go in, just so everyone knows what to expect, or are you happy for people to enter now?
Well, I'll just quickly say that hopefully these bullet points represent things that people have been forewarned about and have had the opportunity to give a little bit of thought to before today, and these are what we're going to be discussing. So let's jump in and crack on.
Thank you.
And I've just posted these questions on the slide into the chat as well, so you can see them in different ways. Okay, I'll open all the rooms now.
So we've got 4 groups. We're going to take, 2 minutes feedback from each group? Was that the idea? I think so.
1 minute. 1 minute.
Okay. Shall we start with you, Helen, since I can see your face on the screen?
Thank you. Okay, so the main theme was that PPI impact is often seen as small practical changes. You know, you think it's a huge amorphous thing you've got to get through, but actually it isn't, especially rewriting patient information sheets, improving recruitment materials, and you can easily track those changes and see what the impact has been. My group also stressed the importance of the feedback loop. Contributors want to know what changed, what didn't, and why. And then the measurement came up as both qualitative and quantitative, not just recruitment numbers or how many people attended a focus group, but whether people felt heard and whether the work actually improved decisions. So that comes back to the you said we did. And then trust and relationships were another big point, with being invited back being seen as a sign that involvement is genuinely valued. I mean, overall, the group agreed that PPIE works best when it's specific, measurable, and closed loop, rather than just tokenistic. Thank you.
Thank you, Helen. Who would like to take their minutes fame next? Linda?
Yes, our group unsurprisingly covered a lot of the same. The way that we can actually prove how impactful it can be, how important that is to our motivations. Were all about giving something back for what we'd had, but the other thing was being brave and standing up to sometimes the negative responses you got at first from researchers, and having the confidence to say no and to make sure that what we were doing was going to actually be impactful and not just ticking a box, and how important that was.
Thank you, Linda. Kaz?
Actually, me and Brian were a bit like a 1980s game show. We were each other's glamorous assistants. So what I'll do is I'll hand it over to Brian, because I know he was taking notes while we were going through it. Is that okay, Brian? Yeah.
Of course, yeah. So I think there was a lot of discussion around similar things, around how important it is once individuals are embedded earlier, the impact that they can have, as well as one example is how they've driven research specifically, where researchers were not going to investigate a specific research area, but because of the patient and public representative being there and driving awkward conversations that may be awkward for the clinicians or the researchers, has then resulted in important and impactful research in the end. And also communication breakdowns or assumptions around, individual contributors, that maybe, making that space available so that it's okay to say, oh, I don't understand this. I want to learn more, and maybe changing process. So like not having a set process at the start, and it being okay to kind of mess with that as we learn in the middle of a process to go, actually, this isn't serving our purpose. So I think even those examples there, as well as, the kind of makeup of PPIE individuals across the world, and how there are different voices coming through, which can make it difficult for people to want to maintain and continue to participate in PPIE work across the research cycle. I hope that was succinct enough, and please, anyone in the group, if I missed something, please contribute.
Unusually succinct, Brian. Thank you. So for the group I was in, really interesting conversation. I mean, the points that came, that seemed to be shouted out to me was how important lived experience is, and that PPIE reps really should be people with experience, and kind of almost preference in terms of recruitment should be given to those groups. There was also some discussion about how people with diverse needs in terms of participation are not always accommodated as well as they might be, and that sometimes people have to push back against those who are doing the recruitment because of, or those who are running the groups, because of different needs in terms of joining and technical ability and willingness to be on camera and so forth. And there was also quite an interesting, surprising discussion I found around, I guess you might call professional PPIE reps who don't necessarily have lived experience of a particular condition, but are very forceful in pushing themselves forward, and are largely interested in the remuneration side of things rather than in the actual cause of PPIE and how organizations might benefit and how patients should benefit from that conversation. And I'm going to just quickly say to the people who are in my group, thanks very much for a really good discussion. If there's anything that I haven't mentioned that you think should be mentioned, please take the opportunity now to say it. Thank you. Okay, well, I think I must have got that right, which is good. So I think it's over next to you, Kaz.
Yep, that's right. Thank you. So I suppose we've had an enjoyable few, a few webinars in terms of obviously this being webinar 3 of 3, and in terms of what we've gone through, what we've learned, and I suppose a bit of the journey we've gone through overall. So hopefully what I'm going to try to do is summarize the learnings from the webinars, and maybe some extra discussion points, which hopefully I think at the end we'll have a bit of chance for maybe 5-10 minutes of discussion. So if you could go to the next slide, please. And of course, if I do run through these quickly, there will be slides going out later. So in terms of webinar 1, why sharing data matters, the key learnings and messages we got from that basically were aimed at from the patient data to real world examples. In the first session, we looked at why people may choose to share their data and why they may hesitate. The key learnings were people are often willing to share data when privacy, purpose, and safeguards are clear. Secondly, they want to see trust, transparency, and meaningful consent are essential. Number 3, people want to know what happens to their data after you've shared it. 4, feedback and reciprocity matters. Patients want to know what their contributions is doing. I mean, did we make a difference? 5, real-world evidence can lead to practical examples in care, treatment, treatment access and safety. And I suppose the message coming from the first webinar is data sharing is not a technical process. It depends on trust, relationships, and showing patients that their contributions have value. Next slide, please. Webinar 2, we moved on to trust and transparency. So moving from the impact, in the second session, we looked at more around how trust, transparency, and PPI can actually be measured in practice. The key learnings were that counting activity is useful, but it does not tell the full story. Second, we need to ask what changed because patients and the public were involved, so what impact did PPI actually have? Quantitative measures that helped us with patterns and scale and the numbers side of things. And then we had a qualitative insight, which helps us understand the meaning and the experience behind the numbers. I remember seeing a comment earlier about acronyms, so I suppose I'm setting myself up for a fall here. But tools such as GRIP2, PIRIT, NIHR standards, PEDRI, PIAF, and PPIE, I think I'm doing myself no favours here as well, and can support different parts of the measurement process. What we will do is, along with the slides, we will send you the acronym, the expanded version of these acronyms. Good measurement combines, so I suppose the overall message being good measurement combines numbers and stories. If we only count activity, we may miss the real influence of PPIE. And finally, today, next slide, please. We had webinar 3, so we were measuring cultural change, which has been the main, I suppose, topic. We were embedding patient voices into how organizations work. In the final session today, we brought together the discussion into practice by focusing on people, culture, and organizational change. And I suppose the key learnings were PPI can influence staff attitudes, decision-making, and organization responsiveness. Number 2, impact is not only seen in the final outcome, it can be seen how people think, communicate, and make decisions at all stages of the process. 3, patient involvement should be embedded through the research lifestyle and not added at the end. It should be part of the process. 4, measuring culture means that looking at what changes inside the organization as what changes for patients and how organizations are positively influenced, winning hearts and minds. And finally, number 5, honest reporting matters, including what worked, what was difficult, and what still needs to be improved. In terms of PPIE, I suppose the message, PPIE impacts is not only about what happens when what we produce. It's also about how patient voices shape the way we work. And before I just hand back over to Jeff, I'm just reading the question there. Is there any research evidence passing on to feedback about research? It seems obvious. Actually, that came up in one of the discussions we were actually having in the breakout session. So hopefully, I suppose that can be the first Jeff session. I mean, that could be the first question, Jeff, when we move into the breakout and discussion. But in terms of the summary and key takeaways, so embedding patient voices into how organizations work. In the final session today, I suppose we brought together the discussion into practice by focusing on people, culture, and organizational change. And I'm guessing in many of the breakout sessions we had, that was a big part of what we were talking about. I suppose some of the key learnings are start with the purpose, define success with patients, measure activity, but it doesn't stop there, capture influence and change, combine numbers with stories, and report back and close the loop. I suppose that encompasses pretty much all 3 webinars, or maybe, I suppose, a takeaway that we can start to implement. And in summary, PPIE impact measurement should not simply prove that involvement happened. It should help us understand what changed, what was learned, and how patient voices made the work better. So remember, we're not talking about that tick box, we're talking about real life changes. Next slide, please. And on that note, I will hand over to Jeff so we can, I'll just hand over to Jeff. Thanks, Jeff.
Thanks, Kaz. I think me and Kaz are getting to be like Ant and Dec.
I'm just glad you didn't say Chuckle Brothers.
Kaz and Jeff. I'll see if I can get some visuals of Kaz and Jeff then. Okay.
That would be good. Yeah, excellent. Yeah, because we're very similar, as you can tell. I was going to, Kaz, you've stolen my thunder though. I was going to be really sophisticated and suave and say, I'm going to open this up for questions now. And I can see a question in the comments, which is for Kaz. Is there any research evidence that participants do want feedback about research? It seems obvious, but a reference would help convince research teams.
I suppose I could just I tried to blag that one, but really, I think it would probably make a stronger point if we could back it up with a statistic, wouldn't it? So yeah, we'll take that on board, because I think we could all, if we went around the room now, we could all give examples of when we've experienced that. But I think, I think I'll try to make sure we include something statistical or something in the future. But yeah, thanks for that, Brenda.
Yeah, thanks, Brenda. Chris has got his hand up.
Well, just to make an offer, if we're coming with questions where we want to ask a wider audience, we can always send questions on the back of this out to Use My Data membership. That'll go out to 500 people. So if we're asking for evidence where patients have said, we really want to see some results, whatever the question is, there's an opportunity to ask a whole range of people for their thoughts and inputs, not just us.
Thanks, Chris. Margaret, you have your hand up.
Just quickly, I have recently had quite a lot of problems with explaining how important feedback is, but not only to participants, also to PPIE people. And it's been really difficult to convince that newsletters, all this sort of thing is really important. We do need, as PPIE, to be kept involved and informed as well.
Absolutely. And I guess that goes somewhat to Chris's point as well, doesn't it, around polling the membership to look for more support for that notion. So we have about 7 minutes left before the webinar will end. Any further questions at this point? Reshma?
Do you know, I think it would be an idea if we were to involve health economics into PPIE surveys and actually prove how much money was saved and the impact of our research. That would be a statistics. The statistics that they produce would actually be the most valuable, in my personal opinion. So I think health economics is one now to ask them to evaluate savings. Please, thank you.
Anybody from the team want to pick that one up? No is the answer. Chris? Oh, sorry.
I was only going to say it's a perfect question to put out to members again, because lots of our members have been involved in loads and loads of research projects and things in the past. So some of them will involve health economics. So if there is evidence out there, our members might know about these things.
Yeah. Yes. Kaz, did you have something you wanted to say?
No, I was going to say, based on what Reshma just mentioned, it's not like she talked about the savings, but because of PPIE, how much funding was actually given, or how many opportunities, or maybe I suppose a better way to put it is, how many opportunities weren't missed because of good PPIE involvement.
Thanks, Kaz. So we have just a few minutes left. Do we have any further questions? Oh, Linda, your hand's up. Linda, I think you're on mute.
Moira had posted asking about a fourth webinar so we can share our learning from these sessions, and there's quite a lot of positive response to that. It's in the chat.
Yeah, thank you.
And I think a similar question from Abby around, what's next for Flatiron. And so just to caveat this, it's the PVP rather than Flatiron. So I think as the PVP have developed over the last 5 years, that they're driving a lot of this themselves and individually. So that this, and maybe some of the guys will say more on this, but this was initially just to talk more about how we measure impact. The hope will be that we will hold ourselves accountable to all this chat, and that this time next year we'll come back with some measurements, some impact that we can say over the last year. All these pieces of work that we've done have had some impact in some aspect of either the individuals' lives or wider to like other work that's happening. So I think that's the aim really. It's like the starter for like discussion around what impact looks like, and then for the panel then to do more work throughout the year, gather feedback, gather insights, and then hopefully reach out to Chris again next year and say, hi, we've got some stuff that we'd like to feedback again.
Thanks, Brian. Come to you in a moment, Chris, but Margaret's had her hand up for a minute or two. Margaret?
I just wanted to say that a particular group that I worked with, probably 15 years ago, I've been involved, by the way, for over 25 years. Recently, I was asked again to contribute, and the ability to pay PPIE for time had improved tremendously. And they actually said it was from all the work that they've done in the past. So I must go back to them and ask them what sort of proof they were able to put forward. And I think it was an NIHR grant that we got.
Okay, thank you, Margaret. Chris?
Well, I was only going to say, in terms of where we go from here, there's a whole bunch of stuff. One of the practical things that Janet and I were mulling over was something we've been trying to do with Use My Data for a while, which is develop a small learning package of people who are coming into data and PPIE. What is data? How does it work? What does my data look like? A sort of a learning module, a learning pack. But actually, if you think about what we've done here, learning it is one thing, implementing it, make a practical difference is another. So lots of the learnings from here would actually really fit well to extend that as a proper end-to-end pack for anybody coming into patient involvement and data fresh. So I think that's something I'm going to drop Janet and Brian a line, and I'll then have to go and talk to the Use My Data executive group, one of whom is here, about the sort of things we want to be doing, which is what's the most important. Can we manage to do these sort of things?
Brilliant. Thank you, Chris. And I think we've got time for one more question. Reshma.
Yeah, I mentioned it to Linda in our breakout room, but as the panel is all together now, and I want to reiterate the point, is that could we convince our Chancellor that taxing people for the work that we do for PPI is a little bit vicious? I mean, this is a labor of love, of dedication, of actually saving the nation. I mean, I won't elucidate all the wondrous thing that PPI achieves.
Yep.
I think that this is something to think about, is that, the small amount of money that people get on it, then to sort of hound them. Is there something that we could do about that? Not that, I mean, I think maybe the new government might be more nice to us than Rachel will, but there you go. I just thought I would mention it.
That's a great idea, and I'm going to email my MP as soon as this meeting's over to demand that they start taxing the payment.
We've been trying to do this for 25 years. I've had so many arguments with MPs, all sorts of people. I'm sure I can see Chris smiling. I think he understands what I'm saying.
Yeah, but I think it's something we need to keep going at, and I do think writing to your MP is a good idea. I know, for instance, talked with Andy Burnham at a session. He was really interested in particular in use of data for metastatic breast cancer. So he might be an influential person in the future. But I think individually we've each got to play our role in that, making small incremental gains.
Well, I guess we're at the end of our allotted time. So can I, on behalf of the Flatiron PVP, thank everybody for a brilliant meeting, really great participation, and really thoroughly enjoyable, and more than that, really informative and educational from my perspective. So thanks to everybody. I guess there might be a fourth meeting coming along at some point in the future, but we don't have a date for that yet, but I'm sure Chris will keep everybody in the loop. So from me, as the host, if you like, for the meeting, thanks very much to everybody for being here, and it's been a really interesting Friday morning for me.
Thank you,
Yeah, thanks all
Jeff.
the team.
Thank
Thank you, everybody.
Thank you.
Have a good
Thank you.
weekend.
Bye. You too. Thank you.
Thank
Thanks.
you.
Thank you. Take care.